Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on today's video. On today's video, we're in session number 4 of our new and ongoing series entitled X-rays and Medical Research in the QME Evaluation. And I have a fascinating program for you today. We're going to talk about a fairly commonly encountered condition of the wrist, which is frequently encountered in the wrist pain population. So I'm sure that you will run across this condition at some point in your career as a qualified medical evaluator if you have not already run across it, or the principles that we're going to discuss in today's video are generally applicable principles to every single one of your evaluations. So you might think of today's discussion on the wrist condition that we're going to talk about as sort of a metaphor for all of your other cases, and a metaphor for how to use X-rays and medical research for the resolution of disputed issues in your cases, regardless of the condition being evaluated. So I have a fascinating discussion for you today, and before we get into that, let's just talk about where we've come so far in this series. In session 1 of this series, I talked about the necessity of ordering diagnostic X-rays on every single case that you evaluate in chapters 15, 16, and 17. And when the X-rays that you order demonstrate concerning or significant positive findings, that creates an opportunity for you to conduct medical research on the significance of those findings as it relates to your examinee's particular circumstance. And this medical research is what you can use to support your opinions and conclusions in the remaining sections of your report. For example, in the causation section, in the permanent impairment section, and in the apportionment sections of your report. And both the combination of the X-rays and the medical research are going to lend substantial medical evidence to your opinions and conclusions in those critical sections of your report. So I want you to imagine a scenario where this could portray itself out in deposition, for example. Imagine yourself at a deposition and one of the attorneys is challenging you on your opinions and conclusions on, say, apportionment, for example. And I'm just making this up as an illustrative example. You're being challenged on your apportionment determination. And the attorney says to you, well, doctor, you opined ABC in terms of apportionment. Is that correct? And you confirm that that is indeed correct. And the attorney takes the next step and he says, well, doctor, can you tell us upon which facts, what relevant facts do you rely upon for your apportionment determination? And this is where you pull out the relevant facts that you derived from your medical research. Medical research that is derived from the relevant and current scientific literature on the particular medical condition at issue with your evaluation. So it's the medical research and the findings of the X-ray studies that are going to lend credence and support and substantial medical evidence to your opinions and conclusions. And I can't tell you how many times I review qualified medical evaluators' reports when they support their opinions and conclusions with some sort of a generic statement such as the following. They'll say something similar to the following, either in part or in entirety. They'll say, this is usually in a separate paragraph in the report. It'll say, the above opinions and conclusions are based upon the history, the records, my exam, and my 65 years in evaluating same and similar cases. something like that, okay? And I can tell you that if I was a deposing attorney deposing this particular doctor, and I asked the doctor, upon what relevant facts are your opinions and conclusions based? And the doctor told me that it was based on the history, on my exam, on the medical records, and my 55 years of evaluating similar cases. I would look the doctor straight in the eye and say, well, doctor, can you be a little more specific? In other words, you need to have specific and relevant, concrete facts upon which your opinions and conclusions are based, and the x-rays and the medical research are perfect for this. The medical research specifically provides you current citations from the relevant medical literature upon which you can substantially provide opinions and conclusions. Okay? So that was the entirety of our discussion in session number 1, and I hope you have taken this to heart, and I hope you implement 2 procedures from session number 1, and that is you order or begin to order the diagnostic studies in every single case from here on out, and number 2, that you start to begin to incorporate medical research within the body of your report, because in the future, if the new proposed regulations of the complexity factors, in other words, new proposed changes to CCR 9795 are actually adopted and written into law, the Division of Workers' Compensation will favor reports that incorporate medical research. So we don't have to wait for the passage of any new laws to begin to incorporate the spirit of the proposed changes, and that is that our reports should be based upon relevant citations from the medical literature. Okay? So that was session number 1. And then in session number 2, we demonstrated those 2 principles in the case of a cervical spine anomaly known as a ponticulus posticus. And we reviewed the x-rays, we did the necessary measurements on the x-rays that are required for the AMA guides, and we incorporated medical research to arrive at our opinions and conclusions on impairment and apportionment, and I shared those opinions exactly as they were written by the qualified medical evaluator with you. In our last session, we employed the same principles as relates to a wrist injury case, and we talked about the condition described in Chapter 16 of the AMA guides, known as carpal instability. Carpal instability. And carpal instability is a fascinating concept and applies to any of your upper extremity cases, especially those cases that involved a direct injury to the wrist, such as a fall on an outstretched hand. So how often do we get those cases? We get those cases quite often, don't we? So many doctors are intimidated and a bit overwhelmed by the procedure for ordering the necessary x-rays and then doing the actual measurements on the x-rays to assess for carpal instability, but you need not be intimidated by it at all. It's actually quite simple and it's quite fun to do. And we went over those 5 different measurements that are required by the AMA guides in our last session. So in today's session, I want to build upon our last session as relates to carpal instability and introduce to you a new finding on wrist x-rays that requires medical research to determine the significance of that finding on the examinee's overall circumstance. So I hope that you will find this to be a very fascinating discussion, and perhaps you've never even heard of this condition that we're going to discuss, or perhaps you have heard of it but haven't considered as to how it applies in the industrial setting. So we're going to get into that right now. Okay, so our case today that I want to share with you involves a 52-year-old female who had a 6-month duration of employment as a lumber yard secretary. She was the secretary at a lumber yard. Well, of course, she was hired as a secretary, but this job involves some multitasking. In general, her duties involve secretarial and computer-based type of data entry and ordering of product and managing shipments of product and handling payroll and all of the secretarial duties at the lumberyard, but also when the lumberyard found themselves short-staffed or in need of uncalled for services, she would perform whatever services were necessary to help the lumberyard maintain its operations. So she described a gradual increase due to repetitive and cumulative trauma, a gradual increase in right wrist pain, mostly on the dorsum of the wrist and more on the ulnar aspect of the wrist. Well, the wrist pain became exacerbated and aggravated one day when she went out into the lumber yard and she assisted in loading of some pieces of wood, some 6x6 pieces of wood into a customer's pickup bed truck. She stated that this significantly accelerated and aggravated what was already a worsening pain developing in the dorsal ulnar side of her wrist. Well, she came in to the qualified medical evaluation complaining of right wrist pain, right wrist weakness, and some numbness, intermittent numbness and tingling in the ulnar distribution of the wrist and hand. So mostly in the ring and the pinky finger and in the hypothenar pad of the right hand. And by way of relevant medical history, she described a prior quote-unquote fracture of her right wrist approximately a decade ago. And there were no medical records to detail this prior wrist injury, and her recollection of the incident was fuzzy at best, but she described a fall from a bicycle onto an outstretched right hand about 10 years ago, and she stated that when she was evaluated medically, she was diagnosed with a hairline fracture, quote unquote, a hairline fracture. Well, when I asked her what bone in the wrist or hand suffered a hairline fracture, she was vague and she could not respond anatomically as to which bone was the involved bone that suffered this quote-unquote fracture. Well, the treatment for this prior wrist fracture involved simply activity modification and an ACE bandage wrapping. There was no casting, there was no follow-up care, there was no physical therapy, and she gradually resumed normal function, but it wasn't until she was hired at the lumber yard did wrist pain symptoms begin to manifest themselves. Okay, so that was the history of the mechanism of the injury of the lumber yard right wrist pain. Well, she presented to the occupational clinic, and at the occupational clinic they ordered x-rays of the right wrist to investigate right wrist pain. And let's review the report of the medical radiologist. Okay, and here are the findings of the medical radiologist. He tells us that the carpal bones of the right wrist appear to be intact and the joint spaces are preserved. There is no acute fracture or bony destruction or periosteal reaction seen. The radiocarpal joint is maintained. The bones of the distal forearm appear intact. Only the minus variance is seen. The soft tissues appear maintained. So the impressions are that there's a normal right wrist without fracture or misalignment, and incidental ulna minus variance is noted, and this may be associated with triangular fibrocartilage tears. Now, many of you, if you received this report from the medical radiologist, would have no idea what a minus variance, ulna minus variance is, or what the significance of that condition is as it relates to this particular examinee. Now, I'm a practicing chiropractor, and I have heard of this condition. I'm aware that the ulna can have both positive and minus variances compared to the adjacent radius bone. However, this is not something that we deal with commonly on a routine basis, and even in my case, this is a condition that I'd long ago forgotten about. This is simply something I ran across once either in chiropractic college or at some point later on in an x-ray course, but even though I'd heard of this condition, I had no idea what the significance of this condition was, and that may be the case with you as well. So when you get a report like this from the medical radiologist, if there are terms or conditions that are described in the medical radiologist report that you don't understand, this is the opportunity for you to do medical research to understand, number one, what is this particular description or what is this particular condition? And number two, what is the significance of this condition as it relates to your particular examinee? This particular condition, whatever it may be on whatever x-ray studies you order, in this case it's an ulnar minus variance condition, but whatever the condition is may have impact on your examinee's particular circumstance. The condition, for example, may impact the direction of the medical treatment that you recommend for the particular examinee. The medical finding, the medical condition may have impact on the examinee's permanent impairment. The medical condition may impact your apportionment determination in determining the approximate percentage of the permanent impairment due to the industrial injury and the approximate percentage of permanent impairment due to other factors. In this case, these medical findings may constitute your other factors to which you may apportion some percentage of the permanent impairment. So when you find these conditions and you see these descriptions in any type of medical report, such as an imaging report, such as an electrodiagnostic study report, such as in an MRI report, such as in a specialist report, this creates the opportunity and it also creates the obligation for you to do medical research to explain to us, who are the readers of the report, what does this condition mean and what is the significance of this condition as it relates to this particular examinee. Okay? So this is the medical radiologist's report of the x-ray findings. Let's go over the examination findings on the day of the qualified medical evaluation. And here are some of those findings. To palpation, the examinee had tenderness to palpation over the dorsum of the wrist at the distal radio-ulnar joint, particularly on the ulnar side of the joint and particularly at the interosseous space between the distal ulna and the distal radius. She had tenderness to palpation of the ulnar styloid process. And on passive range of motion testing to assess for dissociative type of carpal instability, in other words, instability across the radiocarpal joint, she had pain on dorsal and ventral glide of the distal radial and ulnar joint. She had pain on passive pronation and supination of the wrist at the end ranges of both pronation and supination. Tests for dissociative carpal instability, such as the Watson test and the lunotriquetral ballottement test, were both negative. The grip strength was decreased, with the right wrist grip strength approximately 50% of the left wrist grip strength. She also had weakness to manual muscle testing in resisted right wrist flexion, right wrist extension, right wrist radial deviation, and right wrist ulnar deviation. Now, this is an interesting examination procedure. The AMA guides do not describe manual muscle testing to the wrist. In Chapter 16, the AMA guides do describe manual muscle testing of the shoulder and also of the elbow, but they do not describe strength testing by manual muscle testing of the wrist. But it's my suggestion to you that you begin to incorporate manual muscle testing of the wrist as well. And in those cases where your examinee has weakness to resisted manual muscle testing at the wrist, this is something that you can use to provide permanent impairment due to loss of function, due to loss of strength of the wrist. And I'll show you how we create an analogy to loss of strength at the wrist in just a few minutes. The active range of motion of the wrist was normal. She had greater than AMA guides normal wrist dorsiflexion, greater than normal palmar flexion, much greater than normal radial and ulnar deviation, and she had full range of motion in both wrist pronation and supination, with pain at the end ranges of both pronation and supination. Okay, and so because the history was significant for a prior fall on an outstretched hand, and because the current medical history was significant for an unknown etiology of cumulative trauma pain to the right wrist, the X-ray studies that are described in the AMA guides for the assessment of carpal instability were required. In other words, it became required that we assess this particular examinee for the presence or the absence of right wrist impairment due to carpal instability. So we went ahead and ordered the necessary diagnostic studies, and it became time to take a look at what the medical radiologist referred to as negative ulnar variance. Okay, so when you get your x-rays, the procedure for measuring for ulnar variance is as follows, and I'm going to share with you two different methods that are described in the medical literature for this assessment. And they're both basically the same or very similar types of measurement procedures. So method number one is where the length of the ulna is compared to that of the radius by drawing a line perpendicular to the long axis of the radius from the most proximal point of the radial articular surface. Okay, so this involves drawing two lines. One is drawing a line down the long axis of the radius, and then number two, drawing a line perpendicular to that touches the distal radial articular surface. Okay, it's the distal radial articular surface, the more proximal point, which is at the medial aspect of the radial articular surface. And I'll demonstrate that to you. Normally, the distal ulnar articular surface should not project beyond this line, this perpendicular line. When the ulna is proximal to the perpendicular line, the diagnosis of negative ulnar variance is confirmed. On the other hand, when the ulnar articular surface lies distal to the perpendicular line, this is confirmatory for positive ulnar variance. So in the first example, the ulna bone comes up short of the perpendicular line. In the second example, in the case of a positive ulnar variance, the ulna comes up long compared to the radial articular line. And a mental note here for you as you go through these measurements, the variance of the ulna is independent of the length of the ulnar styloid process. In other words, we don't use the ulnar styloid process in making our measurements. We use the ulnar articular surface. Okay? You can get false positives for positive ulnar variance when you conduct your assessment using the ulnar styloid process compared to the ulnar articular surface. Okay? And then method number two is very similar. We're going to draw two lines. We're going to draw one line tangential to the articular surface of the ulna and perpendicular to the shaft of the ulna. And then we're going to compare that to another line drawn tangential to the articular surface of the radius, which is also perpendicular to a line down the shaft of the radius. And I'll demonstrate that to you as well. Then we're going to measure the distance between these two lines. Now, in what's referred to as a neutral ulna or a neutral ulnar variance, there is no distance between these two lines. These lines are collinear with each other, and they have a 0 millimeter distance between the two lines. If the ulnar tangent is distal to the radial tangent, this is a positive ulnar variance. And if the ulnar tangent is proximal to the radial tangent, as in the case that we're going to review today, that is referred to as a negative ulnar variance. Okay? Okay, so here we have the x-ray studies, and this is the neutral P to 8 of the wrist. So let's assess for ulnar variance in this particular image. So using method number 1, we're going to draw a line perpendicular to a line down the long axis of the radius and use that to assess for the length of the ulnar bone. So here's the radius bone, here's the ulnar bone, here's the scaphoid, here's the lunate, here's the triquetrum, and underneath is the pisiform over here. And this space here is filled by connective tissue. That's where the triangular fibrocartilage is. So you can see that conditions affecting the length of the ulna have great impact on the integrity of the triangular fibrocartilage, as well as other conditions affecting the wrist, as we'll see. So let's draw our measurement lines. We're going to create a perpendicular line up the axis of the radius bone and draw a tangent line perpendicular to that. So we'll make sure that we have a 90-degree angle to the most proximal aspect of the radial articular surface. So let's draw that in, and let's adjust this line here so that it's more in line with the axis of the radius bone as the radius bone continues on down. And then we'll adjust this line so that it approaches 90 degrees. So right about in here, there's a 90-degree angle. So this is a perpendicular line that's perpendicular to the long axis of the radius bone. And if we continue this line laterally, you can see that the ulna does not quite measure up to this perpendicular line. So there's some shortening, even though it may be a small amount of shortening of the ulna bone in relation to the radius bone. Okay, so this would be described as an ulna minus variant. And then our other measure involves drawing a second line, and that has to do with a tangential line across the articular surface of the ulna, again forming a right angle with a line perpendicular to its shaft. So that would look like this. There's a line about perpendicular to the shaft of the radius. And then we'll draw a second line adjacent to the articular surface of the ulna at a 90-degree angle. Which would look about like that. Let's raise that up. Good. And now that we have our two lines and our two reference points of the most proximal aspect of the radial articular surface and the most proximal aspect of the ulnar articular surface, let's draw a line and measure the distance between those two. So let's see if our software will allow this. Let's leave that line intact, and let's just measure it. Let's say out here a little bit away from these lines so that we can get a measurement. Oh, it's going to be difficult to do. In fact, let's remove this. Let's remove that, and then let's just draw a line between these two reference points. Here's the most proximal aspect of the radial articular surface, and let's draw that down to this line. And that's given us a differential of approximately 1.41 millimeters of negative ulnar variance. And this is going to dramatically affect the way forces are relayed across the radiocarpal joint. Ordinarily, we would expect these lines to be relatively collinear and in alignment with each other, with the ulnar bone projecting more superiorly than it currently is here in this image. So this is approximately a 1.41 millimeter negative ulnar variance. So when you see this type of report from the medical radiologist and you do the actual measurements on the actual X-ray images yourselves, in other words, don't simply rely on the reported findings of the medical radiologist, you need to confirm these findings with your own measurements. And it's okay if your own measurements are slightly different or even completely different from those of the medical radiologist, because in the end, you're going to rely upon someone's opinions and conclusion, and it's best that you rely on your own opinion and conclusion. So you need to reconcile any discrepancies between your findings and those of the medical radiologist, but always, always, always conduct your own assessment of the images and your own assessment of the measurements on the images yourself, okay? So when you see these findings and you confirm these findings, you ask yourself, what is the significance of these findings as relates to this particular examinee? And this is where your medical research becomes pivotal in helping you arrive ultimately at the opinions and conclusions in the later sections of your report. So in this case, I wondered that very question to myself. What is the significance of this condition? How does this relate to the examinee's need for medical care? How does it relate to her causation, AOE, COE determination? How does it relate to impairment, etc.? So one source of medical research that I was able to locate was an X-ray radiology textbook known as Yoakum and Rose Essentials of Skeletal Radiology, and you may be familiar with this reference. They have a section or a chapter specifically dedicated to congenital anomalies and what are referred to as normal skeletal variants. And I provided the page references here for the reader of the report. And here's what the medical research has to say about this particular condition. Tell us that if you look through the literature, this particular condition may be also referred to as a radial ulnar index. It may be referred to as a short ulna syndrome. It may be referred to as ulnar abutment syndrome as well. And it's important that you provide this for the reader of the report, because what's the reader of the report going to do when they see these terms within the body of your report? They're likely going to do a Google search on some of these terms, and this Google search will bring them right to information very consistent with what is described by you in the medical research section of your very own report, okay? And the medical research tells us, as a bit of a background information, and this is for the benefit of the reader of the report, tells us that if the radius and ulnar articular surfaces are in the same plane, in other words, collinear, the configuration is termed neutral variance, and this is normal. However, when the ulna is relatively short, the appearance is referred to as a negative or a minus ulnar variance, and if the ulna is longer than the radius, it's termed a positive or a plus ulnar variance. So we begin our medical research by giving the reader of the report a little bit of background about this condition. And then we share with the reader some of the clinical significance of the particular condition known as negative ulnar variance. The medical research tells us that the relative lengths of the radius and ulna are important factors in dispersing compressive forces across the wrist joint, also known as the proximal carpal joint. Ulnar variance may occur as a developmental variant or secondary to traumatic or inflammatory causes. In this particular case, I'm suspecting that the examinee had a traumatic secondary ulnar variance. It was secondary to a prior wrist fracture approximately 10 years prior. It tells us that a change in variance of 1 millimeter can alter the radio-ulnar mechanical transfer characteristics by 25%. And this has marked implication for individuals who perform repetitive loaded rotational movements. So in our particular examinee, she does perform repetitive movements, both as a secretary and also as a multitasker at the lumbar yard, and she had a variance of approximately 1.4 millimeters, approximately 40% greater than even the minimum described here in this particular reference source. This research goes on to tell us that the triangular fibrocartilage complex at the distal ulna is thicker in patients with a negative ulnar variance, and surgical shortening of the radius by osteotomy is a common treatment in the management of Kienbach's disease. We'll talk about Kienbach's disease in a moment. Whereas ulnar osteotomy may be undertaken for ulnar compartment syndromes from a positive ulnar variance. So this gives us some idea as to what some of the potential medical treatment options are for examinees who have negative ulnar variance. Sometimes this requires a surgical shortening of the radius in order to even up the radius and the ulna bone so that they again assume a collinear type of relationship. Okay? So this is all important medical research that provides the reader of the report words and understanding that perhaps you might not be able to deliver to the reader of the report based upon your medical experience or knowledge of this particular condition. And this is an example where the medical research does a great job in educating the reader of the report in a way probably much better than you could ever do yourself. So this is a perfect example as to how to incorporate valuable medical research within the body of your report. Okay, and so we give the reader of the report some background information about this condition, and then we really start to build our case with citations from the medical references that support what our opinions and conclusions are going to be later on within the body of the report. So here is an example of that. We tell the reader of the report, by extracting this citation from the medical research, that shortening of the ulna, in other words, a negative ulnar variance, has been implicated in avascular necrosis of the lunate wrist bone. Avascular necrosis of the lunate wrist bone, also known as Kienbach's disease, although some reports have not supported this contention. So here we're starting to build our case that the examinee has a serious condition in the wrist. This condition may affect more than just the ulna bone itself. It affects the wrist at the radiocarpal joint. It also affects the wrist within the intercarpal joints due to avascular necrosis of the lunate, causing shrinking and death of the lunate bone due to lack of blood supply. So we're starting to set the stage for some of the permanent impairments that we're going to provide the examinee later on in the impairment section of the report. Further, separation of the scaphoid bone from the lunate bone owing to disruption of the scapholunate ligament, also known as scapholunate dissociation. This can occur causing rotation of the scaphoid on a short ulna, which can happen in 50% of cases. And when the ulna is very short, such as greater than a 5 millimeter disparity, a painful pseudoarthrosis can develop between the radius and the ulna, contributing to what is known as a radio-ulnar impaction syndrome. So here we provide references to the reader of the report that's going to support and contribute to our diagnosis of this particular condition, as well as our opinions and conclusions on impairment later on in the report. And for your understanding of this condition, and you may include something like this within the body of your report, as they say, a picture is worth 1,000 words. So this is a graphical description or portrayal of the distal radial ulnar joint in cases where the ulna is neutral. In other words, there's collinearity between the two articular surfaces. In that case, the head of the ulna bone assumes sort of a cylindrical configuration, whereas in an ulnar positive condition, the head of the ulna bone creates or assumes a more spherical type of configuration. Whereas in our particular case with the ulnar negative variance due to shortening of the ulna bone, the head of the ulna assumes more of a cone shape configuration, and this affects its articulation here with the sigmoid notch of the radius bone here. And when the ulna bone is particularly short, it can create a painful pseudoarthrosis down here, which is a source of pain and loss of function of the wrist. And that formed the basis of my clinical opinion on this particular examinee, that this particular examinee suffered a traumatic shortening of the ulna bone due to prior hairline fracture approximately 10 years ago due to a fall on an outstretched hand when she fell from the bicycle. The traumatic shortening of the ulna bone has created a painful pseudoarthrosis here at the distal radial ulnar joint and is affecting the mechanical transfer of load across the radiocarpal joint, as we'll see. So here is a diagrammatic representation of this. Imagine this. This is the superior surface here of the radius bone, and this is the scaphoid fossa here. This is the lunate fossa here. And here is the distal radial ulnar joint here, with the head of the ulna bone being received here by the sigmoid notch of the radius bone. Well, in a lateral view of the sigmoid notch here, notice that the sigmoid notch and the lunate fossa are contiguous. And with shortening of the lunate bone, with shortening of the ulna bone, that creates an incongruity here between the receptive articular surface on the radius bone at the sigmoid notch with the articular surface of the ulna bone at the distal ulna, creating a painful pseudoarthrosis here and disrupting the mechanical transfer of loads here across the radiocarpal joint. And as far as mechanical transfer of loads across the distal radial ulnar joint and the radiocarpal joint, the medical research tells us that in cases of neutral ulnar variance, in other words, when the radius and ulna are collinear or have less than a 1 millimeter either positive or negative differential, that 80% of the loads transfer through the radius bone and 20% of the load is supported through the ulnocarpal articulation. So this is load transfer across the radiocarpal articulation, and this is transfer across the ulnocarpal articulation through the triangular fibrocartilage. Well, our particular examinee had a negative ulnar variance of approximately 1.4 millimeters, and the research tells us that this changes the mechanical transfer of loads, increasing the amount of load transmitted through the radiocarpal joint and diminishing the load through the ulnocarpal joint. So imagine that articulation through the scaphoid fossa and the lunate fossa and the increased loading across the radiocarpal joint through those particular articulations of the radioscaphoid articulation and the radiolunate articulation. And imagine how that could affect also the transfer of forces through the scapholunate articulation and through the scapholunate ligament. That will increase stress and cause dissociation over time through the scapholunate articulation. And in cases where the ulnar variance is even greater than 1 millimeter, we see an increased transfer of forces again through the radius and a diminished transfer of forces through the ulnar bone. So this medical research is critical to the development of our clinical decision making in this case. The medical research guides us and tells us that this particular examinee has additional comorbidities in the form of at least a possible pseudo-articulation at the distal radial ulnar joint, and possibly also contributing to a dissociative form of carpal instability at the scapholunate articulation due to alterations and anomalous mechanical transfer of loads across the radiocarpal articulation. So with these clinical hypotheses in the back of our mind, how does this affect our impairment formulation in this particular examinee? Let's take a look at some of the different possibilities that exist for the permanent impairment rating for this particular examinee. Well, one possibility that exists for this particular examinee has to do with permanent impairment due to loss of strength. Now, in Chapter 16 of the AMA Guides, the AMA Guides do not describe loss of strength of the wrist joints and loss of strength of wrist motions. They do describe in Table 1635 impairment due to loss of strength of the shoulder and of the elbow, but the table does not include impairment values for loss of strength of the wrist. And in my opinion, and I've done this in the past, you should perform manual muscle testing of wrist motions. The wrist has at least 6 motions. It has flexion, extension, radial and ulnar deviation, and pronation and supination. And even though the AMA guides do not describe permanent impairment due to loss of wrist strength, it's my opinion that loss of wrist strength is an unlisted condition in the AMA guides that can be compared to these listed conditions. In other words, the shoulder and the elbow are listed conditions, whereas the elbow would be an unlisted condition, but you can provide for permanent impairment by analogy to these listed conditions by determining a percentage loss of strength of the wrist and multiplying the percentage loss of strength of the wrist by the relative value of the wrist, just as they do for the relative value of the shoulder and the relative value of the elbow, however, with one slight modification, which I'll share with you in just a moment. Another option for the permanent impairment of this particular examinee would be to provide for permanent impairment due to loss of grip strength. And in this particular examinee, we determined that she had approximately a 50% loss of grip strength of the right dominant hand compared to the non-dominant left hand. So we could determine a strength loss index by comparing her strength compared to what the AMA guides describe as normal strength values for similar age-matched females, and coming up with a strength loss index, and then simply providing for permanent impairment by doing the necessary calculation in Chapter 16 for loss of grip strength. Okay, so there's 2 permanent impairment possibilities due to loss of strength at the wrist. And I'll show you how we provide for permanent impairment due to loss of strength to resisted manual muscle testing here in just a moment. So to do that, we have to put a couple of facts together. Well, we start on page 502 with the AMA guides and what they tell us regarding carpal instability. They tell us that in considering the non-dissociative forms of carpal instability, in other words, the forms of carpal instability that involve the radiocarpal joint, the radiocarpal joint represents 40% of the upper extremity, and they reference table 1618 for this statement. And we'll take a look at table 1618. And then they tell us that for mild, moderate, and severe instabilities of the wrist, we multiply 20%, 40%, or 60% by the maximum value of the radiocarpal joint, which is 40%, to come up with impairment values of 8%, 16%, and 24%. So this gives us a basis for providing a permanent impairment due to what we refer to as the direct estimate method. With the direct estimate method, we know from table 1618 that the maximum value of the radiocarpal joint is 40% upper extremity impairment. The maximum value for impairment of the entire wrist, meaning the radiocarpal joint, the proximal row of carpals, the proximal to the distal row of carpals, the entire wrist, is 60%. The maximum value of the distal radio-ulnar joint is 20%. The maximum value of the proximal carpal row is 30%. Well, in this particular examinee, we could conceivably, based on what we've discussed so far, we could provide for a permanent impairment rating due to loss of function of the radiocarpal joint, due to ulnar negative variance, and altered mechanical transfer of loads across the radiocarpal joint. We could also provide for impairment due to dysfunction or loss of function of the distal radio-ulnar joint due to the development of an anomalous pseudo-articulation at the distal radio-ulnar joint. We could conceivably provide also for a permanent impairment rating due to scapholunate dissociation at the proximal carpal row if that was supported by the appropriate physical examination findings and or the appropriate diagnostic x-ray findings. And we did not go through those measurements in this particular case, but I can tell you from my own knowledge and my own experience with doing those measurements on this case, the measurements for dissociative carpal instability, such as scapholunate dissociation and lunotriquetral dissociation, were negative. But you could have an examinee who had a more chronic form of this condition, which over time and due to altered mechanical transfer of forces across the radiocarpal joint could shake loose and break down the scapholunate ligament or the lunotriquetral ligament over time and actually cause a dissociative form of carpal instability that could be detected by your measurements on the x-rays. And so conceivably your examinee could qualify for one of the dissociative forms of carpal instability, or they could conceivably, in this examinee, could conceivably qualify for permanent impairment due to loss of function of the entire wrist due to a combination of all of these findings that we've discussed. Okay? So if you determine, say for example, you determine that the examinee had a loss of approximately 50% of her strength of the wrist, considering loss of strength in flexion, loss of strength in extension, and all the motions of the wrist, you could conceivably come up with an estimate of the loss of the function of the wrist and multiply that loss of function by the maximum impairment value of that particular joint. So if you concluded that the examinee had, say for example, a 25% loss of function of the entire wrist, considering loss of strength in 6 ranges of motion, you would simply multiply the 25% times the 60% to come up with a 15% upper extremity impairment value, which you would then convert to a whole person impairment value using table 16-3. So this would be an example of how to use the direct estimate loss of function of the wrist in coming up with your permanent impairment rating by using table 16 and the values that are provided for each of the various articulations of the wrist. And then finally, you could simply provide for a permanent impairment rating by analogy to carpal instability as described in table 1625 in chapter 16. So while this examinee doesn't qualify for the exact descriptions of carpal instability described in this table, you could provide for an impairment rating by analogy. So we know that this examinee has dysfunction and loss of function, including pain and activity limitations and limitations with activities of daily living due to loss of function of the radiocarpal joint. We know that she has pain and loss of function of the distal radio-ulnar joint. We know that in time this examinee is likely going to suffer some scapholunate or lunotriquetral dissociation due to altered mechanical transfer across the radiocarpal joint. So this examinee has conditions that are unlisted conditions that can be analogized to these listed conditions that are described under the standard strict application of the AMA guides, strictly described as carpal instability conditions. So you can use table 1625 to analogize to a mild, to a moderate, or even to a severe carpal instability pattern. And in this example, this case example, you would be completely justified in analogizing at least to a moderate carpal instability pattern at 16% upper extremity impairment, which would be roughly consistent to what we just described as a 15% upper extremity impairment due to the direct estimate method of rating loss of function of the wrist under the direct estimate method. So here we show at least two examples where the permanent impairment rating are roughly consistent even using different measurements. So really, you're only limited by your imagination and using the four corners of the AMA guides to come up with analogies to describe the permanent impairment in cases similar to this one. So doctors, I hope this helps you. This particular case involves a specific anomalous condition in the wrist known as ulnar negative variance, but this discussion applies to any condition that you find anywhere in the body. The purpose of presenting you this case is to share with you how the x-rays and how medical research are critical in helping you develop your clinical impressions on the particular case, and then how your clinical impressions contribute to your final opinions and conclusions in your report. In this particular case, as an example, how could we ever determine the examinee's condition without ordering the necessary diagnostic studies? Without the necessary diagnostic studies, we would never have discovered the ulnar negative variance condition. Without discovering the ulnar negative variance condition, we would never know that the examinee could have a painful pseudo-articulation at the distal radio-ulnar joint. Without knowing that there's a painful and pseudo-articulation at the distal radio-ulnar joint, we would never understand that this examinee is suffering from altered mechanical transfer of forces across the radiocarpal joint, and how this particular anomalous joint would be subject to early breakdown and easy injury due to repetitive and cumulative traumas, and specifically could be overwhelmed by a specific incident of lifting heavy lumber pieces of material at the lumber yard. So this case perfectly illustrates how the necessary and required x-rays, which are then supported by medical research, is pivotal in arriving at the true condition and at the true conclusions regarding this particular examinee. So I encourage you to adopt two new steps if you're not already doing those. And that is, number one, to order the necessary and required x-rays on every single case. And then in those cases where the x-rays present with abnormal positive findings, it's necessary that you incorporate medical research into the body of your report to explain, first of all, to yourself, and then second, to explain to the reader of the report what the heck this condition is, and number two, what is the impact of this condition on the examinee's particular circumstance. And when you incorporate the necessary X-ray studies and support your opinions and conclusions with relevant and current citations from the medical literature, your opinions and conclusions will be irrefutable. And they will also be, most likely, the correct and accurate opinions and conclusions for your particular examinee. And after all, that's what we're all really after. So this is Dr. Perry Carpenter. I want to thank you for taking the time to join me on this week's discussion. Look to be with you on future discussions as well. And for now, I'm wishing you the best success in your career as a qualified medical